All right. Welcome to the ISHLT Pharmacy Professional Community Webinar, Transplant Smarter, Streamline Care, Reduce Cost, and Boost Outcomes. The ISHLT Professional Community Webinars are free and open to all. After the webinar, it will be available on YouTube. If you're not a member of ISHLT, please consider joining. My name is Amanda Ingemi. I'm a transplant pharmacy specialist at Centera Health, and I am joined by Richard Woody Lincoln, clinical pharmacy specialist, heart transplant at Banner University in Phoenix, and Dr. Paolo Grossi, infectious disease physician, University in Serbia in Italy. We are in for a treat today, some exciting presentations from 4 of our speakers here. We ask that if you have any questions for our speakers, that you enter them in the chat. And after all 3 presentations are done, we'll open it up for discussion with the presenters. We'd like to start off with Dr. Michael Shullo, Vice President, Transplant, West Virginia University Hospitals. He's going to be presenting on less is more, labs that you can spare to spare your time.
Thank you, Amanda. I appreciate the opportunity to speak today and the invitation to talk on this topic. Whenever I was initially asked to sort of discuss this and talk about labs that are excessive sort of surveillance, if you will, I sat back and I talked to a few colleagues, several colleagues, and asked about if they thought we drew labs too much or did too much testing. And everyone invariably had the same answer. It was, yes, we definitely do. We shouldn't test this much. But the vast majority of folks simply didn't recognize that it was a problem, that testing caused issues. They had reasons and rationales on why they would do it. My job today, in the short time that I have, is to show you that actually there is a problem. We shouldn't be testing, and we should use a little more discretion when we're ordering types of surveillance. So I have no relevant financial disclosures. So let's start with what we test. What are the things we test in transplant, and particularly in thoracic transplant? We do general labs, CBC, BMP, sort of various minerals and electrolytes based on what we do as a hospital. We do disease-specific labs. We're looking for certain things in screening. We may do a BNP, G6PD, etc. We routinely check immunosuppression levels, medication levels, anti-infective levels, things along those lines. We do a whole myriad of immune monitoring, from things like Silex to things like molecular diagnostics, antibody testing. And as part of testing, we do test for rejection. So we do invasive testing, biopsies, and other things along those lines. We go into the nuance and the detail of looking at HLA and anti-HLA testing, DSA, cell-free DNA, GEP. We have acronyms for everything, and we test for them all. We also test for infection surveillance. We look at lots of serologies. We look at PCR, cultures, infectious antigens, and other things along those lines. And we all know we do an awful lot of imaging. And that's part of the testing world of what we use. So why do we do it? Well, we do it for diagnostics. We do it for a differential diagnosis. We do it for drug monitoring to make sure that the chemicals that we give folks to fool their organs into believing that they should be there are at what we think are the right levels. We do it for organ system monitoring. We also do immune response monitoring, and we also look for infection. The bigger question, this is when I asked several colleagues and talked to lots of folks over the years, is why we do it. We do it. These are the arguments I get back when I ask a question. Well, why are we doing that? Is it going to change our outcome? The reality is we do a lot of testing to make ourselves feel better. In particular, we do it out of worry. Are we missing something? We do it because, hey, that's what I was taught. You know, I've worked with lots of folks over the years that train in lots of really big institutions from a lot of really smart people. And that's what they told them to do. So you know what? We're testing for it. A lot of times we just make stuff up. Somebody may not know the answer to the question, so the answer is we need more testing. And frequently, and I can say this happens very commonly, at least in the institutions where I have practiced and or worked, is for convenience. We don't want to have to think about what's the next thing that we should surveil. So how do we do it? Well, we test per protocol. Every transplant institution around the world that does that sort of does thoracic transplants has some sort of protocol or policy. We do it per order set. They're automatic, and they go, and they may be open-ended order sets. We do it by individual or differential or diagnostic testing. We may think that we need to figure out which is which. Is it A or is it B? Which is the right direction? We do that kind of testing specifically on certain areas. And many times we do it by individual preference. You may have a new person on service, a new colleague that says, listen, I really like to look for this particular testing. I test again at these intervals, and this is what I want. So the $1 million question is, do we test too much, and does it matter? Well, unequivocally, we do. I can tell you that we do test too much. And talking to colleagues and friends over the years, as I mentioned, everyone recognizes we test too much. What they don't get, and where the disconnect is does it matter? You know, what's another tube of blood? What's another 5 mLs out of sort of a green top? Does it make a difference? And I can tell you unequivocally it does. We do excessive testing in patients who are stable. We do excessive testing on drug levels. We do excessive testing on screening for things. We do excessive immunologic testing and infectious disease testing. And a great example I have in here is, you know, we frequently will test at the back end of treatment from a treatment course we know works, but we'll still do additional testing. So why does it matter? Well, it matters for a couple of reasons. We know that unnecessary testing, whether that be blood work, X-rays, or other surveillance, increases morbidity. It increases length of stay. It decreases the patient quality of life. It increases mortality, increases cost, decreases clinical education if you're in that type of institution, and increases global workload of the people who are involved. So over-testing itself can hurt patients. HAA, which is hospital-acquired anemia, occurs in about 25% of admissions if they stay greater than 2 days, frequently requiring a blood transfusion. Now, that's defined by coming with a normal H&H and ending up with a hemoglobin less than 11, or requiring a transfusion. So if you think about the volume of blood draws that we do, we cause anemia. How many of you have had patients that you've cared for and they came into the hospital for their transplant? They've received a transplant, or they come in for follow-up. And then at the end of their admission at day 11 or day 12 or day 14, based on your length of stay, now you're chasing anemia you didn't have. So we have a population of patients that we're giving toxic chemicals to that inhibit their ability to make hemoglobin, and we're taking it out faster than the body can create it. We create this problem. And 25% of admissions equals a lot of people that stay in the hospital longer than they need to be, which goes right to length of stay and readmission. Patients who have excessive blood draws and end up with hospital-acquired anemia end up with readmissions more often and stay in the hospital much too longer. There's a dramatic decrease in quality of life for this population for patients who are getting too many blood draws or too much testing. They have disrupted sleep. They have an increase in pain. They have an increase in bruising and vascular injuries. Now, you'll notice I have an arrow on the screen that's pointing to the side. And over there are 2 questions. And this is somewhat US-centric, and I apologize to my international colleagues, but as part of some of the areas that hospitals are graded on are something called HCAHPS in the US. And 2 of the questions in HCAHPS are specific to patients and their quality of life. One of those is, did you get the rest you needed? And during the hospital stay, how often at night, how often around your room was it quiet at night? Those go directly to excessive testing. So if you're up and you're waking patients up at night to get blood draws or send them for X-rays or do things that they don't necessarily need, you're impacting their quality of life. And your institution will receive a lower grade based on these responses. The other areas where over-testing hurts patients is the over-treatment and under-treatment of diseases. So you may do a test on a patient that you think that it's sort of a screening that you do on everyone. You may find an equivocal result. And what that means is you're going to test them more and test them again, and you're going to test them again. And you may treat them for something that is normal for them and may not be abnormal. And then lastly, the data is pretty clear. There is clearly an increase in mortality in patients that are over-tested and end up specifically with HAA or other issues. Another thing to think about is testing can be mind-numbing and create unnecessary work. Every test that's ordered that is not needed, for example, if you order tests on autopilot, they impair critical thinking in an educational medical model. So if you work in an academic medical center and you have students, residents, interns that need to learn about how to care for patients, if it's always automatic and they don't have to think why and how, they do not learn. It also increases workload unnecessarily for the entire team, for the physicians involved, for the nurses involved, for the pharmacists, for all the folks that follow up on either blood work or testing. And in addition to that, we tend to draw blood work at the wrong time. And troughs, especially for transplant coordinators, if it's not a trough or for floor staff, they have a really hard time interpreting and frequently make the wrong decision. And then there's increased pressure to respond to testing. If you do a test and the patient is slightly abnormal, you feel as if you have to do something. Especially young practitioners who are used to making intervention, they don't have the sort of the history of taking a step back and looking at the bigger picture. They frequently will act and overtreat because there's a fear of missing something, of missing things in the big picture because they're not able to do it. And testing is expensive. The literature tells you that it's about $150 a day in the US. That you spend for excessive testing. I would argue it's much higher than that. I have an example of this. The dates have been changed to protect the innocent, but the reality is this is an example of a patient that was admitted to the hospital for a transplant themselves. They received the transplant, they did very well, were completely rock solid stable. And as you can see, they had a basic metabolic panel drawn every single day for the 12 days they were here, at $271 a day. So for 12-day stay, that's $3,252 just for this particular test. That doesn't count all the others that have been ordered at the same time. So let's get granular to a degree. How about specific tests? So examples are you have a patient that's completely stable. Their BMP has been stable for days. Their CBC has been stable for days. And you did some surveillance chest x-rays, but they continue to get daily testing. The reality is all you're doing is causing harm. Another example is immunosuppression and initiation and management. Frequently, what will happen is a person will be initiated on immunosuppression, and we'll use tacrolimus for an example. They get admitted to the hospital, and then post-op day 0 or post-op day 1, they'll get a blood draw the next morning. They just got a dose. It's not possible for them to have detectable levels or a level to the degree that would be either toxic at that point, unless there's some other confounder. So it's best in that case to wait till maybe post-op day 2. Or if you make a change in their therapy, wait until the drug is at least close to half-life, at least a day, or at least 2 days, perhaps even 3 would be ideal. And that goes the same for other drugs that have excessively long half-lives. Some of the other drugs themselves have half-lives in excess of 24 hours. So if you initiate a patient on sort of sirolimus, for example, and the patient's on the therapy, and we test the level daily, the level is not going to hit steady state for a week. So the reality is there's no use in testing that patient at that point. Now, the argument you may hear back is, well, I'm afraid they'll get toxic if we overshoot. But the reality is you can still test, but not daily, to verify that you're not overshooting. The other areas of an example is poor level timing. A random tacrolimus level helps no one. Just like a random vancomycin level helps no one. You need to order it at the right time for the right patient. And then what you find is you will draw levels, for example, on immunosuppressants, and you make decisions on bad data. You'll draw a trough that's premature before the patient's at steady state, and you'll think they're low. So what happens? The team adjusts it. And then 2 days later, the patient's toxic because they've overshot, because they made an adjustment before they should have actually made the intervention or made the assessment of the level. Other examples are immunologic testing and rejection testing. We will get tissue typing on a person, test their HLA to find out where they are. And then people will do it again and again. Their HLA types don't change. One test is adequate. Another thing is antibody timing. Frequently, you have a patient that will receive blood, and they'll say, we need to check antibodies. And we'll check antibodies 2, 3, 4 days later to see if they mounted a response. It's not clinically possible to mount an antibody response to blood that quickly, or many other things. Or if you have a patient that's received an organ and you recheck, some people will recheck sort of antibodies much sooner than they could ever mount a new de novo response to antibodies to that particular organ. Molecular diagnostics, we will check, so for example, people will check a GEP or an AlloMap in a heart patient who is on too high of a dose of, say steroids, or they had recently received Neupogen and it's not the right time to do it. Or we may biopsy. A patient may come in with non-symptomatic rejection. For example, in a heart, they have a 2R, you give them steroids, and you may want to recheck the biopsy within a week or at a week. It really is not going to give you the answer you want. You're just going to test again. Other examples are repeating cultures or testing after a treatment course is done. So if you treat a patient with antibiotics themselves, and you know, for a UTI or whatever you choose to treat, and the patient is asymptomatic and all the other numbers have improved, there's really no need to recheck cultures. And that goes the same for checking x-rays after a treatment course. And lastly, just doing a pan culture as a screening technique. You're going to find things you don't want to find and things that don't need to be treated. So what are the solutions? The solutions I would offer today are do intentional testing. Daily labs don't have to be daily. They can be every other day once they're stable. Check levels at the right time. Wait for the drug to be closer to half-life. Get to the approximate time to actually have a level you can do something with. Check serologies, for example, if a patient has been exposed to other serologies pre-transplant. If they were CMV positive pre-transplant, they're going to be CMV positive post-transplant. There's no reason to recheck that serology. And lastly on that, know how the test works. If you're doing a test, make sure you understand what exactly it's testing. And then on the last part I have is do intentional focus screening. If you're looking for something for an infection, or you want to do radiology or imaging, make sure you know what you're looking for. Same with antibodies and cultures. And don't test something you know it's likely to be negative. If a person is on anti-CMV therapy that is known to be highly effective, there is really no reason to routinely check them for CMV. Cytomegalovirus virus is treated well, it's covered. You don't need to keep checking. And is there support? There's tons of it. There's lots of societies that come back and say, basically, don't do serial testing or blood. Don't do this, don't do that. It's been supported from various societies all over the world. So in conclusion, I believe an intentional and selective approach to testing instead of routine, automatic, or blanket testing improves patient care and reduces clinician time with unnecessary interventions. Thank you.
All right, thank you to Dr. Shullo for your excellent presentation. Again, please place any questions that we may have in the chat, and we'll address them after all talks have been completed. It is now my pleasure to introduce Dr. Stephanie Yasheko, clinical pharmacy specialist at Cincinnati Children's Hospital Medical Center, who primarily practices in lung transplantation.
All right. Thank you so much for that, Dr. Shullo and Woody. I appreciate that introduction. Again, hello, everyone. As mentioned, my name is Stephanie, and I am a pharmacy clinical specialist at Cincinnati Children's Hospital in Cincinnati, Ohio, USA, and I will be delivering talk 2 today on medication stewardship. The title of my presentation is RX Reimagined, Simplifying Medications to Streamline Complications and Discharge. I have no relevant financial relationships to disclose in relation to the content of this presentation. So by the end of my presentation, my goal for you all will be able to define poly and hyperpolypharmacy, describe common causes of polypharmacy in solid organ transplant recipients throughout the continuum of care, decrease risk factors for the development of and outcomes associated with polypharmacy and medication regimen complexity within the solid organ transplant population, and finally, to understand how the principles of medication stewardship can be utilized to prevent and or reduce polypharmacy and medication regimen complexity in solid organ transplantation. So throughout the span of a solid organ transplant recipient's journey, we all know that they move throughout a complex network of care phases that ultimately begins at the time of evaluation. However, for the purposes of this schematic and illustration here, I'm going to start out our continuum of care once the patient enters the OR. So here, the patient will likely receive some sort of induction immunosuppression regimen, a series of antimicrobials, analgesia and sedation, as well as potentially some vasoactives for hemodynamic support. And we know that most all, if not all of them, of these perioperative medications will continue beyond the OR setting and follow the patient right to the ICU, where even more medications will be added to the mix. Here, we may decide to restart some home medications, start maintenance immunosuppression, initiate prophylactic antimicrobials, stress ulcer prophylaxis, potentially anticoagulation, and the patients are likely going to still be on some sort of sedation and pain regimen at this time. And then eventually, once the patient stabilizes, they transfer care settings and they will head out of the ICU and into an acute care unit. And while the patient will now be typically off vasoactives and heavy sedation, we are probably now all aware of the phenomenon that most patients, once they get to the acute care setting, have stuff that trickled down with them from the ICU, and they're doing pretty well, and no one feels comfortable with stopping it. So even more medications are added on from that standpoint as well. And then finally, once the patient reaches discharge readiness and shows up for their first ambulatory care visit, they are on an average of around 15 medications. So really, what's the big deal? So in really to pharmacists, this may not seem too bad, considering all that the patient has went through up to get to this point, but it actually is very concerning. And that is because this phenomenon has been defined as polypharmacy, which is defined as the concomitant use of 5 to 9 medications, as well as potentially hyperpolypharmacy, which pertains to the use of 10 or more medications. And there are negative consequences with this because they are associated with lower quality of life, adverse drug effects, drug interactions, prescribing cascades, as well as medication non-adherence. And as displayed in my continuum of care illustration on the previous slide, we all know that it is very easy for a solid organ transplant recipient to fall victim to poly or hyperpolypharmacy. And then ultimately, this potentially can compromise graft and patient survival. So by understanding these consequences, as well as the specific risk factors for development, this may help us as pharmacists to become medication stewards to prevent and or reduce poly and hyperpolypharmacy. So that was exactly the aim of this study presented here by Attic and colleagues as a cross-sectional study. So this was a study that looked at outpatient kidney transplant recipients who were greater than 1 year post-transplant. And the endpoints of this study were predictors of hyperpolypharmacy and medication regimen complexity index. And what they found were that the following factors were associated with hyperpolypharmacy. So patients who were of the male gender, patients who had higher BMI, patients who have worsening graft function, decreased time from transplantation, and those who are of older age. Similarly, older age and worsening graft function were also factors associated with complex medication regimens as well. So the authors were able to conclude here that these factors may indicate that revision of medication lists and other adherence promoting measures may be best suited for older patients and those with worsening graft function. And a similar study was conducted in heart transplant recipients, which evaluated patient-level medication regimen complexity over time. And as you can see here, total medication count at transplant discharge was on a range of 14.3 medications. And if you look at year 1 post-transplant, year 3 post-transplant, all the way up to year 5 post-transplant, that did not vary statistically significant difference, which they pretty much all were similar. So you can see here that this type of complex medication regimen and length of medications pretty much stayed consistent throughout the continuum post-transplant. And then additionally, you can see here as well the percentages of patients meeting either a polypharmacy or a hyperpolypharmacy definition, which also either stayed consistent or, as you can see too, increased in the years following index transplant discharge. So here in table 2 of the same study, they also reported out ranges of medication regimen complexity index scores. So this is known as the PMRCI score, and this is based on the following. So pretty much anything that you can think of that makes your medication regimen complex. So the number of medications, the doses that you're on per day, the units per dose, the dosage form that you're taking, and any special administration instructions. And while there is no specific cutoff value, some of the literature does denote a complex medication regimen as being typically around greater than 25. So with that little bit of background now, you can see here patients' total PMRCI scores were at transplant discharge 37.2, and then again, those persisted throughout the continuum post-transplant all the way up to year 5 with no statistically significant difference. So these studies truly illustrate the need for medication stewardship implementation, especially since we are now aware of the consequences of polypharmacy and medication regimen complexity, in addition to the patient populations who are most at risk for developing this. So therefore, for the remainder of this presentation that I'm giving today, I'm going to focus on a variety of ways that we can implement as pharmacists throughout the solid organ transplant continuum of care, where medication stewardship practices can be implemented to prevent and or reduce polypharmacy and medication regimen complexity. So we'll start off by talking about the intra and post-operative ICU settings. So the 2 big areas that I want to focus on here in these 2 phases of care are going to be induction immunosuppression, as well as peri and post-operative antimicrobials. So starting off with induction immunosuppression, again, as transplant pharmacists, we know that our goals with induction therapy are to both delay, minimize, or potentially outright avoid maintenance immunosuppression agents, and then additionally to decrease the rate of any acute rejection processes. Our most utilized agents to achieve these goals consist of non-lymphodepleting induction, such as basiliximab. Additionally, lymphodepleting induction can be used, which typically consist of either rabbit or equine ATG or antithymocyte globulin, as well as alemtuzumab. So really, utilization of induction is a stewardship technique in and of itself because we're hopefully delaying or at least preventing maintenance immunosuppression. However, I wanted to challenge us to take it one step further, where we could potentially reduce the amount of induction we are administering and still potentially achieve our goals of therapy, which became the question of these 2 studies, investigating the impact of monitoring CD3 counts to guide ATG dosing. So the first study on top here by Uber and colleagues looked at cardiac transplant patients who required antithymocyte globulin therapy and who were dose adjusted to maintain absolute CD3 counts of less than 25 cells per microliter. So the average number of induction ATG doses to achieve a CD3 count of less than 25 was 3, compared to their typical 7-day induction course. And this equated to a 60% dose reduction compared to standard regimen and a 58% reduction in cost per patient, all while still achieving comparable efficacy and safety outpoints. The study on the bottom by Lange's group also looked at this, but approached CD3 monitoring for renal sparing indications as compared to a standard induction group. And what they found was that renal sparing group who was monitored via CD3 counts achieved a lower median cumulative dose in milligrams per kilo of ATG, which was 3.84 compared to 2.37, which was statistically significant. And then also the median time to tacrolimus initiation was statistically significantly longer in the CD3 monitoring group. And then there was no differences in infection or rejection at 6 months. So while induction with ATG utilizing the CD3 monitoring approach allows for less drug maintenance immunosuppression as well in potential steroid withdrawal from an immunosuppression standpoint, I want to now shift gears a little bit to also discuss another large medication component within the peri and post-operative care settings, which is antimicrobial stewardship. And this topic could totally be a presentation in and of itself. It was really hard to pare down exactly what I wanted to talk about, but I did find this really good article that was actually published earlier this year that I encourage everyone to read because it really does talk about more than I can for the time constraints of this presentation. But for the purposes of what I'm going to talk about today, I specifically want to focus on antibiotic allergy delabeling as well as multi-drug resistant organisms. So starting off with beta-lactam allergy delabeling, this is a very big area in which stewardship practices are essential. And that is because transplant patients rely heavily on beta-lactam antibiotics for common infections and empiric surgical treatment. So therefore, when patients self-report a beta-lactam allergy, alternative agents, which are often more broad spectrum, are utilized, which negatively impacts patient care by increasing rates of multi-drug resistant organisms, increasing higher healthcare cost, and increasing hospital length of stay. So successful implementation of skin allergy testing is a valuable, cost-effective tool for antimicrobial stewardship. We actually just initiated a program within the past year at Cincinnati Children's, and it has been very well received at this point, and a lot of patients are utilizing it. And then studies have demonstrated that this type of stewardship practice has demonstrated that up to 95% of patients can be delabeled with subsequent safe administration of the antibiotic in 51% of patients. So then if patients actually go on to develop a multi-drug resistant organism type of infection, we run into even more issues, which creates another opportunity to engage in antimicrobial stewardship-based practices. So currently, evidence evaluating the best approach to perioperative antibiotic prophylaxis and organ transplantation isn't great data. It's really limited to retrospective studies. So recommendations for antibiotic selection often include tailoring for organ type, individual risk factors, and local epidemiologic patterns. So as mentioned, as rates of gram-negative multi-drug resistant organisms begin to rise, expert opinion suggests performing candidate screening to facilitate targeted perioperative antibiotic prophylaxis to mitigate risk of resistance and adverse effects. So some of these interventions could include MRSA nasal swabs if your center is performing those. And even like a newer practice I know is rectal carriage screening, which is taking place in some liver transplant populations as well. So moving along our continuum, I would now like to discuss our stewardship principles that can be implemented in the post-operative acute care setting. And again, I will be discussing two main focus areas to draw our attention to, the first being therapeutic drug monitoring and the second being pharmacogenomics. So looking at maintenance immunosuppression, we are likely all familiar with the fact that these agents, namely calcineurin inhibitors and mycophenolate, are narrow therapeutic index drugs. These create large inter- and intra-patient pharmacokinetic variability, and we know that they are subjected to many drug interactions. So therefore, therapeutic drug monitoring is really essential in maximizing efficacy while minimizing adverse effects. So while whole blood trough concentrations namely correlates with AUC, specifically with tacrolimus, high-risk patient populations, obviously that we know, may warrant AUC-specific monitoring, and this is also the preferred monitoring strategy for patients on mycophenolate when indicated. So while AUC monitoring may be preferred from an efficacy standpoint, it is definitely not preferred from that of a logistical standpoint, and I know this is not lab stewardship when we're talking about going from a single trough estimate to 3 to 4 limited sampling strategies for a patient taking a single dose of mycophenolate or tacrolimus. So this does make implementation a logistical challenge. However, I did want to share how we implemented this at Cincinnati Children's Hospital. And this comes from our translational and clinical pharmacology department that we have really partnered with in the transplant department. Not only do therapeutic drug monitoring, but they also help us with pharmacogenomics as well, as I will explain in the subsequent slide. So utilizing dose modeling and PK software, they are able to help us aid us in determining a therapeutic dose based on a desired trough goal as well. So by partnering with the clinical team and the clinical pharmacology team, we're really able to utilize both sets of teams in order to come up with pretty much the optimal dosing strategy for patients who are high risk or are struggling to become therapeutic. So additionally, like I said, this team really helps us in our pharmacogenomic testing services as well. So for those of you who are unfamiliar, pharmacogenetics is the study of drug interactions with an individual's genetic makeup. This includes molecular testing, and it's utilized to analyze certain genes and how to predict how a patient will metabolize a drug. And this is really honing in on the individualized precision dosing for specific patients. And at Cincinnati Children's, we have one comprehensive pharmacogenomics panel, which can be ordered. So it's one lab draw, but also multiple genes can be tested on it. So the following genes are ran on that single pharmacogenomics panel. So CYP2C19, CYP2C9, CYP2D6, CYP3A5, NUT-T15, as well as TPMT. And in turn, the subsequent genotype or phenotype that results based on the specific test will aid us in determining an individualized dose. Specifically, in transplant, we utilize this heavily for patients who are on azathioprine, tacrolimus, and in lung transplant patients, we are heavy utilizers of voriconazole, so we do appreciate this pharmacogenomic test. So the final portion of my presentation will focus on the last portion of the patient's index journey, which is discharge and ambulatory care. And as this phase of care also very much requires stewardship initiatives as well, since we saw how the polypharmacy phenomenon in medication regimen complexity often persists well beyond that index transplant discharge. So therefore, I'm going to round out my presentation today, focusing on the discussion of continuous comprehensive medication reviews. So a comprehensive medication review or drug utilization review or medication therapy management, while these all are a little bit different in nature, all of the names pretty much get thrown around interchangeably in practice, but the concepts still remain the same and are held constant and are absolutely vital to assess in your patient population, especially as they approach discharge and when they are seen in the ambulatory care setting, especially as those visits become more periodically. So as the pharmacist, you want to carefully evaluate drug-drug interactions, specifically if they're now leaving your institution and they have, access records to outside hospitals and they're seeing providers that are not located within your institution. Any type of drug disease state contraindications that may arise, over or under use of medications, looking at their fill histories, drug food interactions, have they changed their supplements, their feeds, anything that they're getting over the counter that you didn't account for while they were in the hospital because they might not have had access to it at that time. Drug dosage modifications. In pediatrics, specifically when I transplant our younger patients, they outgrow their doses so quickly, specifically as they gain weight and they're healthy post-transplant. So making sure all of those are optimized as they continue to be seen in clinic. Also making sure indication. Typically, sometimes once we start medications, we don't stop them. So basically assessing if they still have the indication for that specific medication to be warranted. Is that medication still efficacious? Is there any safety concerns? Are they having any side effects? And are they adherent to their medication regimen? Because that's the most important thing overall. And then finally, patient access to care and affordability concerns. Are they having any access to getting to the pharmacy? Do they change insurances? All things that can come up in the ambulatory care setting that kind of get missed or sometimes overlooked when they're in the hospital for so long. But I now want to transition over to medication non-adherence, as I just alluded to that on the previous slide. So medication non-adherence is so common post-transplant, especially as they're starting to feel healthy and they feel like they don't need these medications anymore. And we know that poly and hyperpolypharmacy are associated with medication non-adherence, as well as complex medication regimens, because they simply are having issues doing it and handling that mentally. And as discussed, outcomes of medication non-adherence may include increased healthcare cost, rejection, infection, and potentially graft loss. So therefore, medication regimen simplification and decreased pill burden may be successful adherence tools. So simple ways to implement this would just be, knowing their prophylactic stop times, knowing when their next steroid taper is going to be, whether that's to a lower dose or off, or when they can taper next to a lower CNI goal reduction. And then assessing the indication, like I mentioned, for each medication, because sometimes, again, they feel better, they're on lower steroids, they might not have high blood sugar or high blood pressures anymore where they're going to need antihypertensives and things like that. So knowing when to stop medications and really simplify their regimen could go a long way for the patient. On the other hand, if a medication is discontinued and needs to be reinitiated, evaluating the situation and knowing how to best do so will continue to uphold judicious stewardship principles. So a good example of this is antimicrobial prophylaxis. As patients approach 1 year and go beyond that, most, if not all, of their prophylactic agents, well, depending on the organ, are going to be discontinued. So reinitiation may need to occur if a patient develops an infection. This most commonly occurs with CMV, DNA-emia, which is detected on PCR. And currently, there's really no consensus regarding quantitative threshold at which treatment should be reinitiated. And the treatment agents that we do have available often cause a significant amount of adverse effects and tolerability issues. So this can really be a programmatic goal. It could even be a great QAPI initiative as well to implement a type of CMV stewardship program at your transplant center, because this truly has the potential to address the clinical burden of CMV infection or disease, while also making an economic impact. So in summary, solid organ transplant recipients are at risk for both polypharmacy and medication regimen complexity, given their acuity and profound journey throughout the health system's continuum of care. This phenomenon is associated with medication non-adherence, lower quality of life, and adverse drug effects, which ultimately compromise graft and patient survival. So understanding principles of medication stewardship and where and how to implement them can prevent and or reduce polypharmacy and medication regimen complexity in solid organ recipients. The references that I included throughout the presentation are as follows. They were also cited on their respective slides. And that concludes my presentation. Thank you all so much again for your time. I will welcome any questions at the conclusion of the webinar or via email below. So I will now hand it off to our next speakers.
Thank you very much, Dr. ISHLT, for your excellent presentation. Any question can be addressed after the talks. It is now my pleasure to introduce Dr. Steve Ivolich, lead respiratory pharmacist at the Alfred Hospital in Melbourne, Australia, and Yvonne Cristiano, who is the lung transplant liaison nurse coordinator at Alfred Hospital, again in Melbourne, Australia. Please, Dr. Ivolich, the floor is yours.
Thanks, everyone. So I'm going to be talking about transitioning patients to outpatient-based management strategies. The title of the talk is called Mobilising Your Mindset. And Yvonne, my nursing colleague, will be talking at the end of the presentation as well. I have no disclosures. So traditional models of patient care are typically given in the inpatient setting. If we transition patients to outpatient care, this can reduce the hospital length of stay and free up bed resources. There are two potential models that we could talk about, where you have admission avoidance, where you have full substitution for the hospitalisation, or you could have early discharge followed by care at home, which results in a shortened hospitalisation. There are a few pros and cons to moving patients to outpatient care. The most obvious one is inpatient beds cost a lot more. There are a finite number of beds. And we also know that prolonged hospital admissions can be associated with deteriorating cognitive and physical function, increased adverse effects, and mortality. The main drawback that some people say is that by having care at home, you have reduced access to technologies and resources. However, you can have this early on in the admission if patients are going to be discharged early. I'll talk about 3 different models. What we call in Australia the medical day unit, or an outpatient infusion centre, where you can give relatively simple infusions at a day centre. Hospital in the home, where you have acute or subacute treatment in a patient's residence. And ambulatory care, which Yvonne, my colleague, will talk about later on, where you have early discharge from hospital to either rehab or to an outpatient clinic with intense follow-up. The infusion centres, they tend to be nursing-led centres. The patients should be medically stable, and there should be ambulatory as well, where patients can come and go to get the infusions. Administration, most common one is intravenous infusions. You can also get subcutaneous injections as well as blood products. And the other advantage is that you can bloods can be taken at the time, and then they can be followed up by the medical team at a later date. The list of medications that you can give from these outpatient infusion centres is extensive. I'll go through a couple relating to transplant, but the list obviously here is not exhaustive. The most common ones that we tend to give is, say, like methylprednisolone, where you come in each day for about 3 days and you get, say, a 30-minute infusion. Treatments for antibody-mediated rejection, slightly longer. You come in, get a 4-hour infusion. And probably the most complicated one that we would give for in the day unit is the IVIG, where we give quite massive doses for AMR, and we can give these over a few days depending on the daybed availability. As I mentioned, you can give, say, subcut or intravenous infusions, such as with the IVIG or the bortezomib. And you would tend to use drugs in the maintenance phase rather than induction phase. So you give the first doses on the ward, and then later doses, and you can monitor the tolerance, and then later on doses give in the day infusion centre. Other medications that we would give there are, say, CMV, immunoglobulin, infliximab for sarcoid after transplant, or sort of infusions such as zoledronic acid, or even iron infusions as well. So there is a whole big list that we give. Maintenance immunosuppression as well. As conventional immunosuppression is becoming more complex due to intolerance and long-term toxicities, and the number of oral medications is becoming less and less, we are moving to using some of these day infusion units and giving some of our maintenance immunosuppression. Probably the most common one, we have about 130 patients where they would come in once a month to the day centre to receive immunoglobulin. As we have high rates of skin cancer in Australia, this usually replaces the antiproliferative, and it's been incorporated into our maintenance immunosuppression. In the heart or lung settings, we don't use as much here, but I know our renal colleagues use a fair bit more. Belatacept for calcineurin inhibitor avoidance, and these patients come in once a month to the day centre as well. And even ECP, where we're using a lot more of this, having 25 patients where we're using it for CLAD and also to reduce conventional immunosuppression, where they're coming in twice a week or weekly to our haematology centre. However, this is not always available for people, and it is a big time commitment for patients, but it is actually freeing up inpatient beds. I'll talk a little bit about our COVID treatments, so our experience in the last few years. We managed about 700 patients in the outpatient setting, and about 3/4 of these were managed as an outpatient during COVID. We didn't have great outcomes with Paxlovid for our first 2 patients due to drug interactions, even when following the guidelines. So we gave up on that pretty quickly. And then we use remdesivir now as our first-line agent. At the moment, just under half of these patients have received remdesivir in the COVID day unit. They come in each day, if they are well enough, for up to 3 to 5 days. And it's usually about 1 to 2 days for a patient to get access to these treatments. And this actually keeps the majority of these patients outside of the inpatient setting. Pentamidine also, I'll talk about our experience during COVID with pentamidine. During COVID, prior to COVID, we had about 30 patients that would come into the day unit to receive pentamidine for PJP prophylaxis. They come into a sort of a negative pressure room, 6 changes per hour, and these patients were long term. However, overnight we lost access to that due to fears at the time about nebulizing potential COVID particles, and these patients no longer had access to these negative pressure rooms. So what we did, because we didn't really have a lot of other options, so for these patients, if they were stable, we actually taught them to do the therapy themselves with the help of our physio colleagues. They got nebulizers, and then they continued that experience, or the administration of the pentamidine at home. And this setting is actually continued. So in this case, it's actually freed up day unit beds. And our standard procedure now, if someone is suitable, they come in to the day, they come into the ward, do a test dose, and then thereafter they do the rest at home. The next model that I'll talk about is hospital in the home, which is it was a pilot program that started about 30 years ago in Melbourne. And this is where you can have home-based treatment in an episode of acute care. These patients are actually classified as inpatients, even though they are being treated at home. And at any one time, you'd have about 50 to 70 patients in a virtual ward. There's a whole range of indications where patients are treated, but with transplant-related indications, the most common ones that we have are antibiotics, CMV treatments, and also inotropes for heart failure. As you can see from that list, there's a whole range of treatments that are offered. The advantage to hospital in the home is that acute care can be provided to patients in their homes, or say like a nearby hotel, where otherwise it would have been these patients would have been treated in the hospital as an inpatient. And the home treating unit is responsible for the care. That graph there, the little red dot, is the Alfred Hospital in Melbourne. The blue circle is 40 kilometres from the hospital, and they're all eligible for hospital in the home at the Alfred. If patients live outside this catchment area, they can be outsourced to, say, a different hospital in the home. The team consists of a clinical nurse coordinator, a clinician in the community that goes to the patient's house, and allied health such as physiotherapists or dietitians. The HIT pharmacy team is a pharmacist and a technician. Because they are an inpatient, they're responsible for the supply of medications, and they also do the therapeutic drug monitoring, primarily of, say, INR checking, antibiotics such as vancomycin or tobramycin, and also immunosuppressants in conjunction with the home team. Why is hospital in the home important? It is very popular in Australia, and it's pretty widespread, the use. So this article from the Medical Journal of Australia looked at 61 studies, and what they found was that there was no difference in mortality, it prevented readmissions, and there was a high patient satisfaction. And then the same journal actually looked at this 19 hospitals over, say, 7 years with 80,000 admissions, and they found about 4% of those admissions were hospital home related, primarily for antibiotics or for anticoagulation, and they did find that there was a lot more scope to expand that. In terms of heart failure, again, they found that it was safe and effective, and the cost of treating a patient with hospital in the home was about half of that of the treatment within a hospital. So what are the most common medications that we use? So antibiotics are the main ones, so anti-pseudomonals, aminoglycosides, tobramycin and amikacin, mainly glycopeptides, vancomycin, but that list is not exhaustive. We also do long-term antifungals such as liposomal amphotericin and also caspofungin, foscarnet or ganciclovir. Also, most recently becoming more popular is a bacteriophage therapy. Bridging therapies such as furosemide, the inotropes milrinone or dobutamine, and also anticoagulation management, which primarily undertaken by the pharmacists with bridging therapies. I'll spend a little bit of time on the intravenous antibiotics. Normally we have, say, a checklist where the correct patient needs to be selected of, and this for a variety of reasons. Probably the most obvious one is safety, whether the nurse can go to that house. The decision needs to be made whether it's nursing administration or whether the patient will self-administer the antibiotics themselves. The antibiotic can be pre-made, where we outsource that to, say, a company called Baxter. The nurse can prepare it before they go, or the patient prepares it themselves after completing the checklist. All patients will need a central line, so we use a PICC line for short-term or a Hickman's for long-term patients. And the duration can vary as well. There's no sort of set date. So we can give relatively simple antibiotics for a couple of weeks, bridging until transplant. But also we've had patients with, say, Mycobacterium abscessus, and they've been on hospital in the home for, say, 2 to 3 years. There's quite good data on the stability of medication, so that will normally guide of how the antibiotic is administered in terms of what pump or how it's actually made. And these are probably the 3 most common administration devices that we use, either a CAD or an Alaris pump, where I mentioned the Baxter, where these are the pre-made devices which attach to the patient. They're changed each day. As I mentioned, we have some other specialist therapies that are given. So we've given ganciclovir is pretty much standard of care after induction on the ward, and we've had long-term patients on foscarnet where the maintenance is given long-term, say 2 to 3 months on hospital in the home. The duration is usually guided by the viral load, also the tolerance of the patient. It can also accommodate for prehydration as well, depending on the number of lines that are attached. This is mainly relevant for, say, foscarnet or amphotericin. I mentioned bacteriophage, which have a few patients that are on that long-term as well. They're usually stabilised on the ward, given twice daily by the hospital and the home nurses with nebulized therapy as well. I'll talk briefly about the home inotrope program for heart failure. So we usually give this as a support for a bridge to decision or a bridge to transplant. Milrinone is the preferred agent due to the longer half-life, but we also have some patients on dobutamine as well. This is administered by a continuous infusion with a CAD pump at home. There are 2 streams. The traditional one where the HIF nurse goes and visits the patients once a day, where it's pre-made at the hospital when they visit. However, most patients have transitioned to stream 2, where we have about 10 patients on that at the moment, where the patients are taught to change the bag independently via the CAD pump, and they're deemed competent to do that. And then they actually only need to visit the hospital clinic once a week for a line change, and then they are reviewed by the heart failure nurse, the pharmacist, and also the cardiologist. This seems to be the preferred route by patients, and it has been shown to be safe and effective. And patients seem to like it because it gives them more independence, where prior to that, you're needing to wait for the nurse to arrive at the home each day, where now they only need to come into the hospital, say, once a week. And we have a similar program for our patients that are on epoprostenol as well, which I think is about 20 patients. All the bags are preset concentrations. They can either be made by a pharmacy with relatively long shelf life, or we outsource that to Baxter. So they're made and patients only need to come in once a week. I'll talk briefly about anticoagulation, where patients that are supported by mechanical circulatory pumps are taking warfarin. This is a pharmacist-led program where the patient actually reports their point of care INR to the pharmacy team, and then the pharmacist will direct the dosing. So we actually avoid the point of care is validated prior, and then reduces the need for the patient to attend pathology and improves the time within therapeutic range. The cardiology pharmacist wanted to just highlight that the TTR for our program was 76% compared to 55%, which they're very happy with. And again, it's been shown to be safe and effective. So I'll just bring this all together. This is our current protocol for AMR treatments, which we actually use a renal protocol. I'm just saying where patients will come in, or they have to have 3 days of methylpred to start with, and we actually have 3 different options where that can be given, such as the day infusion centre. There is capacity to give that on hospital in the home, or if a patient lives far away, it can still be given on the ward. The Plex and bortezomib will give over 2 weeks. Again, there's 3 different options for the patient to receive those therapies. And then, as I mentioned, the high dose of RVIG, giving 2 grams total over 4 days, where if they're on the ward, they might get it all at once. But again, this provides a little bit of flexibility for the patient about where they live, what actually suits them, rather than bringing them into the hospital for the first 2 weeks. I'll now hand over to my colleague Yvonne, and she'll talk about the outpatient service at the Alfred, how we actually follow up all of these patients.
Thanks, Steve. I'm just going to sort of have a little chat about the outpatient clinic that we run and the role of the outpatient transplant nurse. This is in lung transplant at the Alfred Hospital, so just give an overview. So the Alfred Hospital Lung Transplant Unit sort of runs a model, an outpatient model, where it's a lifelong care. So our patients we follow from the time of transplant through to the end of life. And as the service has developed over time, with increasing transplant numbers and increasing survivorship, we've seen an increase in the number of patients that we're following. So currently in our outpatient area, Steve mentioned, we have 700 patients that we follow routinely through their outpatient pathway. The role of the lung transplant nurse really at this point is to ensure that we can provide support, guidance, clinical care, and really optimise the health and wellbeing of them at home to avoid any sort of unnecessary readmissions and presentation to ED. And I'll go through a couple of the ways that we do this. So the outpatient clinic model is a structure really firstly based around the first 3 months post-transplant, really predominantly to optimise the patient's early discharge, to get them out of hospital or post-transplant as soon as we can, and a really strong rehabilitation model to support that. So patients are seen 3 times a week at the Alfred. They attend for physio with gym, they attend medical appointments, they attend allied health appointments, they have blood tests, they have education, and the aim of that is really just to support them through that transition and a really intense period. Local patients are able to return home during this time, so they come in 3 times a week to the hospital. But our regional and interstate patients will stay in a hotel nearby and be supported through that first 3 months with us in the Alfred. Following the first 3 months rehabilitation period, the patients go out to sort of monthly clinic appointments with us for the first 18 months, and then eventually out to 2 to 3 monthly appointments long-term for the remainder of their life after 18 months. What we do for a bit of a sort of outpatient model is they have routine bronchoscopies. These are performed also as an outpatient to avoid admissions for that purpose. They are done through our day procedure unit, and the patients present back to the clinics about a week after their bronchoscopy to get their results, and any sort of treatments that may be required can be set up within the outpatient area. And then routine disease management surveillance points happens annually on these patients. It's a combination of linking in with appropriate medical teams that may oversee their cardiac or their bone health, and they're managed both either within our outpatient clinic units or the relevant medical teams' outpatient clinic units. To give you an idea of what the model looks like, our outpatient clinic appointments for our patients to sort of really optimise their care, we see approximately 100 patients a week in clinic, and the lighter blue circles are the teams that are available for the patients within the lung transplant outpatient clinic. So while there's the lung transplant physicians, we also have the renal teams, the infectious disease team, psychiatry and endocrine, all embedded within our clinic so patients can be seen at the same time. And outside of that, we have other outpatient areas such as cardiothoracic PAL care that patients can see within the Alfred, but not directly involved in our actual clinics themselves. With the allied health and nursing models, we have a lot of availability for patients within the outpatient clinic to see the lung transplant nurses. We have the respiratory scientists, so the lung function labs there. We have a realm of allied health and also pharmacy available in our clinics. And the idea of this is that it provides a more cohesive model of care. Patients are being able to see a wider team at one time point. We have patients that come in and they will see the respiratory physician. They'll have seen the respiratory science and had their lung function done. They then send endocrine and the diabetes nurse educators and pharmacy to clarify their medication systems and head off. The benefit of this sort of embedded altogether one place shop for care in an outpatient clinic really gives a chance for the teams to work together, the disciplines to collaborate. And because of that, things are sort of acted on more timely, and this in itself can reduce the amount of complications for patients and readmission because we're actively impacting things at that time point. It also gives a really kind of holistic approach to their care as well. As we see the patients lifelong, so we see them indefinitely, we do have a process to be able to support the patients in between clinic appointments with the goal of reducing ED admissions and hopefully also being able to avoid some of the hospital admissions for these patients. One of the methods we have for them is a lung transplant nurse's mobile phone, where the patients will call for any sort of reasons that they need in between their clinic appointments. Averages between about 650 and 700 calls a month at the moment. And in the bottom graph, you can see that there's quite a range of reasons that patients reach out to us. Some of them are unwell, some of them are treatment queries, some of them are after results or blood tests or clarifying appointments. The advantage of this is that we can coordinate them from home. We can give them the support from home. And hopefully by doing that, the nurses will then triage calls, engage with the medical team, engage with maybe the external health providers, and link them into extra appointments and things they might need and sort of coordinate to make sure things aren't going awry. In the event that they do need an admission, that from being unwell as an outpatient, this is an opportunity that the nurses can actually speak to, try and get a direct admit to avoid an ED presentation. They can also engage with the inpatient team to make sure things such as PICC lines are established. They can come in for 24 hours, get their PICC lines, start their antibiotics and go back onto HIF and also reduce their hospital stay. So that's the goal of the overall of that sort of phone, and it's a busy little one, but does a good job. The last thing I want to mention in regards to the ways that we've looked at changing things to an outpatient model is our pre-transplant assessment. Historically, the pre-transplant assessment was done as an inpatient over a 3 to 4 day stay where they came for a realm of tests and appointments. Several years ago, there was consideration given that not all patients need to present for an inpatient assessment, and the outpatient pathway was established for our long-term, for our pre-transplant assessment patients. So they now get seen over a couple of days as an outpatient, and they will come in, they will have all of their investigations booked as an outpatient. It's a really tight schedule. They'll see a lot of the allied health as well. And eventually, once all that sort of collated in those couple of days, they come back probably about a week later to see the doctors in the outpatient clinic to find out the outcome of their assessment and their suitability for transplant. So I think establishing these models that enable and strong outpatient model is essential to be able to support a lifelong model of care and to look after these patients ongoing. If we don't do this, I think we end up with more ED presentations and more hospital stays. And this allows us to avoid those things, but at the same time, it also allows patients to be cared for in their home, which really is a priority of the majority of the transplant patients. And these are our acknowledgements, and thank you for having us speak today.
Thank you.
I'm not sure now how we should do. So apparently the time is over, so I leave the other co-chair to...
Yeah, it looks like all the questions that were put in chat have been answered. I don't know if there's anyone else with any questions before we'll give a few more minutes for people to put questions in the chat. Sounds like additional questions can be posted on Connect. So I just want to say thank you very much for everyone who came. We reached the end of our session. We hope you enjoyed all these talks and learned some new tidbits about transplant management for all of our patients. I'd like to thank everyone who spoke today, Dr. Shullo, Dr. Yasechko, Dr. Uvalich, and Yvonne Cristiano for the excellent talks, and we hope to see you all at the ISHLT meeting in Boston next year.